There are many questions, and we would like to pick up some questions directed to Dr. Richards first. Well, what is the timing to remove the orthosis of the legs? And especially when there is an injury of the ligament, then there is a risk of the re-injury. Therefore, is it necessary to continue to wear the brace or the orthosis to avoid the re-injury? What do you think?
So for the high grade injuries, the research literature would suggest that you only really need for the first 10 days or so, 7 to 10 days, and that would be for grade 3 lateral ankle injuries. But going forwards, you would move from the walker boot into ankle bracing. Now, ankle bracing is a completely different situation, and there have been many people who have performed at elite sport who have worn ankle bracing through their entire elite career. The most notable would be Andy Murray, the tennis player, who wore bilateral ankle braces for all of his career. So it's one of these aspects that some people will get some overcoming kinesiophobia, fear of movement, when wearing ankle bracing, which will then allow them to perform. So when you're thinking about transition out of a walker, then that happens quite early on with ankle injuries, but then moving into wearing an ankle brace. Ankle braces do allow a good range of functional movement, but what they do is just block that end range movement where you have that risk of re-injury. So I would say that transition needs to be managed carefully with education, of course. If we consider the concepts of peace and love, education is critical in there. But once that person has been moved across to the ankle brace, then there are a number of different paths that might go by for how long that is continued for.
Thank you very much. There are a couple of questions here. So the sprain of the ankle joint brace is considered to be quite important. And a little while ago in your presentation, you touched upon a couple of orthosis or the braces. More specifically, how should we think about the types of the braces and also the orthotics to be selected?
Okay, so the selection of the ankle bracing, we are really considering the semi-rigid ankle bracing. I mean, if somebody is really at great risk, then you might want to go for a rigid ankle brace initially, and then move to a semi-rigid. In fact, many designs of ankle bracing will actually have a removable stay within the ankle brace itself, a removable piece within the ankle brace. So it can move from being pretty much a rigid ankle brace to being a semi-rigid. So that transition into going from rigid to semi-rigid for somebody who is at high risk, very high risk of re-injury, could be a viable option.
Thank you very much.
There is one more question to Dr. Richards. And today we have many physiotherapists with us. And about the orthosis of the ankle joint, then oftentimes it may lead to impingement of the ankle joint. And so in the case of training, how long should the orthosis should be worn? And so if it is under the PT or the functional training could be provided under the guidance of the physical therapist without the orthosis. So should they continue to wear even in a training, or can they remove the brace or orthosis under the guidance of and also the observation of the physiotherapist? How can we consider that?
Okay, this is a very good question, and there's also a large amount of variability that you need to consider. In terms of impingement, I'm not entirely sure that you get much impingement with a correctly fitting ankle brace. If it's a rigid ankle brace, then that will obviously block more movement. But the functional movement that we get when wearing an ankle brace is still sufficiently functional for people to perform at really high levels. And what happens is the ankle brace will block that end range, dangerous risk of re-injury movement, but it allows a very good functional range of motion. I would strongly encourage conversations with the patient, with the person who's suffered the injury. If there is a lot of confidence in their movement, then by all means feel free to remove the ankle brace. If there is less confidence in movement and there is fear of movement, fear of re-injury, then you are not doing the patient any favors by removing the ankle brace. All of the rehabilitation exercises you can perform when wearing an ankle brace. The recent work that we've been doing is actually looking at the way the muscles fire, the neuromuscular control of the ankle joint. And there is a strong benefit for the proprioceptive input that you get from an ankle brace, which actually encourages a better recruitment of muscles, including peroneus longus. So you won't get muscle atrophy by wearing an ankle brace. You will get support of the ankle end range to prevent those dangerous end range movements, but you will not reduce the muscle activity. So I would strongly advise that if the patient has any fear of movement or fear of injury or re-injury, then do the rehabilitation exercises whilst wearing the ankle brace, and then consider whether or not the patient can perform the functional tasks when wearing the ankle brace. One of the concerns athletes sometimes have is that they think an ankle brace will reduce performance. If you're dealing with straight run sprint speeds, then there is some evidence to suggest that an ankle brace will slightly reduce your sprint time. But if you're dealing with any movement with changes in direction, there's plenty of evidence out there to say that wearing an ankle brace actually improves shuttle run cutting maneuver timings. So you actually improve the performance, not reduce the performance. So I would strongly consider you use ankle bracing within the rehabilitation protocols. Ankle bracing does not replace physiotherapy. It does not replace rehabilitation. It gives a safe environment in which for you to do the rehabilitation exercises. So I would strongly be advising that the use of ankle bracing within the rehabilitation protocols.
Thank you very much for giving us such a detailed answer. It was very clear for us. From here, we are going to have the general discussion. We would like to ask Dr. Kasahara to join this discussion session. We can here have the general discussions based upon the question from all. So first of all, from myself, as you've discussed in your presentations, but at the same time here in the audience, we probably have a lot of trainers as well. And also, we have PTs working in a hospital. We have doctors. So Dr. Kasahara focused on icing, and Dr. Richard focused on optimal loading in each presentation. But what about the approach for icing in the actual field or in a hospital? First, we'd like to hear the opinions from Dr. Kasahara and Dr. Richard. At actual site of the injury outside of the hospital, what kind of optimal loading is possible to be provided? You might touch upon that in your presentation, but it would be great if you can sort it out in your explanation. So optimal loading outside of the hospital at the site of the injury. So Dr. Kasahara, please. Well, thank you very much. The question is about icing. From the perspective of the recovery or correction of the tissue and pain removal, we have two perspectives here. If the pain is disappeared, in that case, the patient might move and that might lead to something worsening. But if there is pain because of the reaction, the muscle spasm or the excessive contracture of the muscle would take place in the surrounding area. With that, the range of motion and also muscle might be reduced. In order to suppress that, removal of the pain is important. And on top of that, if there is the injury, the secondary dyspnea or the low oxygen level takes place in the surrounding tissue. So you have to deal with that. But of course, if it is acute, severe, or chronic, the situation is different. So in order to separate that, it's not like the absolute icing. There is a case where that you would not do icing, but that selection and decision making is difficult. So if you cannot decide, what should we do? In the case, again, you'd better confirm with the other patient what should be the priority. You need to consult with your own patient to select the appropriate treatment. Thank you very much. Dr. Richards, again, optimal loading. You explained about that, but optimal loading outside of the hospital or immediately after the injury outside of the hospital, what can you do as optimal loading? And also optimal loading in hospital or after the treatment at the hospital. Would you please explain that?
Okay, so well, I mean, if you're deeming immediately after or the onset of an injury, then you will often see the application of ice, but also strapping. So adding in some taping to strap the ankle, to give some more proprioceptive input, but also the ice is very, very important for an anti-inflammatory effect as well. So from that acute point of an injury on the side of a sports field, then I think the application of ice, but also the application of some strapping, taping to give some stability initially back to the ankle, which will protect from further injury or further exacerbation of the injury. But it's interesting to think about the icing from a point of view of, yes, from an analgesic effect, but also an anti-inflammatory effect.
Thank you very much. Now I would like to go back to the given questions. So first, Dr. Kasahara, yesterday, the high school students national baseball game was completed in the KO or high school won the game as a champion. And the cooling time is introduced in the high school baseball game as well. What do you think about the cooling? Well, I'm very hot and excited with that game, so I have to cool it down myself. But the performance perspective and also the prevention of the disease, I think that is important. For this introduction of cooling time, that is to deal with the heat shock status. But to what extent they do the cooling is what we don't know. So it's not difficult for us to verify the effectiveness of that.
And actually, that wasn't applied to the evening match. And therefore, so the goal is really the avoidance of the hyperthermia by cooling the body so that you can avoid the hyperthermia. So I think that it itself was effective, but at the time, it really depends upon what they did. Sometimes that wasn't really helpful at all. So I'm really interested in what they were actually doing. Thank you. Okay, Dr. Richards or Professor Richards, rather. The question is about the taping fixation, and sometimes it is not the reproducible. And what is your idea to the taping in terms of the optimal loading? I just would like to hear your own thought.
Okay, well, taping when done with a physical therapist, physiotherapist, or I think there's going to be some variation. When people are self-taping their ankles, for instance, then there is going to be considerable variation, as you say. There's also some variation in the different tape available from from the use of kinesio tape all the way through to rigid and zinc oxide taping. So, I mean, from a point of view of taping, this is really what you can do right at the point of injury, because you probably haven't got an ankle brace available. But adding in the ankle brace to get that consistency, to get that control, I think is a key thing, a key move to go from taping into ankle bracing. There's been quite a bit of work done on the economics of taping as well. And although taping can be preferred in some situations, in particular collegiate football in the US, when you move out of that environment of collegiate football, then the amount of variability you get in the taping is quite considerable. So we should be moving towards bracing. But looking at the economics between bracing and taping is an interesting one when you consider the amount of time taken to tape individuals. And again, circling back to American collegiate football, then there's an awful lot of time cost from the clinical time for doing the taping. Then actually the bracing actually becomes a far better economic argument than the taping.
Thank you for your answer. So let us now move on to the next question. And I think this question goes both of you to you. And it's about the temperature adjustment or the setting of the icing. And what is your idea? For example, the DJ or Cryo Comfort uh, doesn't allow the good adjustment of the temperature, but it's quite easy to use on the spot. And Japan Sigma Credi 4000, then it allows us to make a temperature adjustment by 1 Celsius. Therefore, what about the impact of the temperature setting to the outcome? Okay, Dr. Kasahara, can you please start? Yes, it's really the challenging question and delicate question, and there are two things. That one point is the first aid, and the other is treatment. So we have to see things from different angles. And from the treatment and conditioning, the too much cooling should be avoided to avoid the bad effect to the performance. But if it is the first aid setting, then you may subside the too much heat, then maybe you can maintain the lower temperature. But of course, you have to consider the right material to cool, but some appropriate temperature or some lower temperature would be necessary in terms of the first aid, but in terms of the conditioning, too cool temperature will be very detrimental to the performance. So you have to have a good temperature control. Do you have any specific temperature recommended? For example, in cooling, and I oftentimes make research on the cool bath or water bath, then 10 to 20 degrees Celsius would be good for the conditioning. So that would be the ideal. But if you cool too much, then you need lots of electricity or too much amount of ice. And then I should say the range of the 10 to 20 degrees Celsius would be the appropriate range. Thank you. Thank you. Now, Professor Richards, what is your idea?
Okay, so I mean, we have done quite a bit of work over the years on different cooling modalities, and I would partially agree that I wouldn't go up as high as 20 degrees, but between 10 and 15 degrees is what we would consider to be therapeutic cooling range. But we have to consider the skin temperature. And when we're thinking about the cooling, we're often thinking about the ice, but not actually thinking about what the end result is on the skin. I'm very much reminded of a paper we wrote in, I think it was about 2007, 2008, where we were looking at a whole range of therapeutic cooling from so water and ice, water immersion, frozen peas. We also tried, and also we also had in there the gel packs. And one of the things that we saw with gel pack, which start off very, very, very cold, because they usually come out of a freezer. So they're usually at minus 17, minus 19 degrees C, which is very cold indeed, of course. And what we saw was an ice burn. And ice burns are very, very bad indeed for the healing. Because they actually you actually end up having tissue damage because of the ice burn, because of the gel pack, which then the body then floods the area with blood, with warm blood, because it thinks that there's this necrotic damage happening. So gel packs really, going too cold is really counterintuitive. So one of the things that we are often thinking about is what the skin temperature is. And the skin temperature should be between 10 and 15 degrees for getting that therapeutic effect. Whether you do that with iced water, water immersion, frozen peas, but what I wouldn't advise is gel pack.
Okay, thank you very much.
Okay, let us move on to the next question. I just would like to ask you your own experiences. And have you ever used the ultrasound to judge the outcome after the icing? We have a portable ultrasound like mute call. And have you ever tried that? Well, okay, let me start. Well, actually, I haven't never tried that, but I already have some access to the equipment, so I want to try it. And if there is an opportunity, then I want to try it, and I like to share my experiences with you. Or if any of you in the audience have some experiences, please tell me. Professor Richards?
Well, we don't use it in any of our research. I mean, obviously there are plenty of papers out there which will probably give you a much better view of outcomes and how it can improve outcomes. But we don't use it within our research, so I can't really comment. But I'm sure that there's plenty of literature out there which will guide any clinical decision making.
Thank you for your answer.
Next question is about optimal loading for the ankle sprain. That's often discussed here, but other joint or other sports injury, for those as well, this concept of optimal loading can be applied, or from earlier phase, or is there any case that optimal loading should not be provided in the earlier phase? Both Professor Richard and Dr. Kasahara, please answer this question. Okay, then let me start. Optimal loading sounds good. However, it's difficult to be actually applied. You have to consult with the patient. When it comes to the load, what kind of load? The load to have the appropriate daily life. So you provide the loading. So for the upper limb, applying too much of the load is not optimal loading. So in such situation, what would be the optimal? Well, in order to find that, you need to consult with the patient. And ideally speaking, the level, the load is bearable, I think it's okay to apply the load. But the amount of the load, the time, it should be started from minimal, and increase that step by step. That's what I think. Professor Richard, please.
So, I mean, to have no load, you're not going to have any of the remodeling. So you need load into the system, and I would agree. We need to start with low loads with severe injuries, and then progress up. Now, we use this term optimal loading, but it's still unclear what optimal would be in the different scenarios. But if we consider somebody with say a grade 3 ankle injury, and we'd quickly progress them from wearing a walker boot, which in essence is offering a lot of protection. You're still getting some loading if people are weight bearing when wearing a walker, so you're giving a lot of protection but some loading. But then you're going to transition them to perhaps a rigid ankle brace, which is going to give us slightly less protection, but a little bit more loading. And then you progress on through looking at a semi-rigid ankle brace, for instance, where you're then going to give a little bit more loading, but again, a little bit less protection. So what we need to be thinking about is the interaction between loading and protection. And these things really are two different perspectives. You know, if you have complete protection, you have no load. And if you have no protection, you have full load. And what the place we need to be living in is this transition between protection and loading. No loading over a long period of time really is not going to be any good for any of the ligaments, any of the injured sites, not to mention it's going to cause atrophy. So, you know, having a situation with no load is really unacceptable. but equally you don't want to put the person at risk for an overload and a re-injury. So I would say you have to look very carefully at the balance between the concepts of protection and loading. And somewhere in there, we can probably define something which is optimal, or at least not suboptimal. I think that there's some subtlety in there, and I think looking at what the patient is needing, how they're needing to progress, will give you some idea of how conservative or how aggressive you want that rehabilitation to be. With a lot of elite athletes, then they're obviously wanting to get back very, very quickly. And the example I showed in my presentation showed a very rapid progression on from what was probably a grade 3 injury back to full play in a very short period of time. Whereas other individuals, you might want to have a more cautious approach if they're not elite athletes. So I think there's this, as I say, this balance between concepts of protection and concepts of loading, and somewhere in that space is optimal loading.
Thank you very much. Well, we are almost running out of time, so this would be the last question. Well, we talked about police or peace and love, and there are many researchers in the audience. And icing or optimal loading, and there still remains lots of areas for further researchers. So to solve those challenges, what kind of researches are necessary? And we would like to ask for your idea as a researcher. Okay, thank you. That's a very challenging but also very important question. Yeah, and I would like to continue to carry out my research on the practitioners or practical approaches. Then I would like to collect many cases. So the case studies will be the very important thing for me. And then why icing wasn't done, or why the laws are given, or whatever. So based on those, the actual examples, we would like to collect those cases and accumulate cases so that of course, everybody has a different ages or different muscle level, one whatsoever, and the situation would be quite different. But with that kind of background, then what cases are properly treated or not? And then with that accumulation of cases, we think we learn things. Yes, randomized approach is very difficult, ethically speaking, right? Well, believe that will be very difficult to do the randomized control study. Therefore, we need to collect cases. Now, Professor Richards, your turn.
Okay, so yes, randomized control trials are notoriously difficult to do in this area. I totally agree. One of the things that we spend a lot of time and energy is looking at patient presentation, a little bit like the case approach that you were describing. But what we are trying to do is to identify clinical subgroups. So within the patient population, we can take any patient population with any condition, and there will be clinical subgroups within that population. Each of those clinical subgroups, you will probably find that there is a different treatment strategy, a different menu of treatment that you would want to try. So I think a lot of the energies that I and I know other researchers are doing right now is to better understand the clinical subgroups as how they present. And then when you have an understanding of what are the clinical subgroups, then you can then start think about targeted treatments for clinical subgroups. So in essence, that then allows the approach, an individualized approach, if you will, based on an individual's where an individual sits within clinical subgroups. So understanding the clinical subgroups and presentations, there will be people, for instance, with chronic ankle injury. There'll be people with pain. There'll be copers and non-copers. Those are some examples of perhaps clinical subgroups, but I think there's far more to it than that, especially if we think about the early management. So I would encourage concepts of understanding clinical subgroups and targeted interventions. And you can do that from large data sets of actually, if you have sufficient data recorded, to then understand what is within different clinical subgroups, or what defines different clinical subgroups. So I think that's a really important area, but it's down to the completeness of the records that we have. So I guess my final comment would be, let's make sure that we're recording all the things that are variables which are important for recovery and for presentation, and make sure that we have that data recorded, because if we have incomplete data, then identifying clinical subgroups is very, very difficult. We need to have complete data sets. So I think there needs to be a consensus on all of the different domains of information and data that are needed. Peace and love is a very good place to start, to look at all the domains that we perhaps need to include, as is police. So these are very important concepts, I think, to help define the areas that we need to categorize or need to collect data on, to then allow as I say, the clinical subgrouping to be performed. So clinical subgrouping for me.
Thank you, Professor Richards. Thank you, Professor Kasahara. Thank you very much for your time. And also, I would like to thank all of you who are with us in this webinar. And I think that that was a very good update information for your actual the clinical practice. And I realize that there are many unknowns yet. Therefore, we would like to further promote, and I would like to ask for involvement the further researchers. There are so many questions, and this actually reflects the very high level of interest. And unfortunately, we had many questions and remain unanswered. We could answer only a part of the questions, but please bear with us. So now it's time to conclude today's session. Thank you. Thank you very much for your presentation and for your time.